Neurologist at South Teess Hospital, but I had the pleasure of completing my PhD alongside Lou when she was doing her MD up at Newcastle University many years ago now, isn't it?
So many of your stationary things.
Absolutely. But Lou is a really engaging speaker. She is a fantastic clinician. They've got really interesting work that's going on here in Teesside, and I'm really excited to hear about more about the work that goes on there. So, without any further ado, over to you, Lou.
My name's Lou. I'm a neurologist at South Teess, but that is James Cook essentially, but also the Ridge Hospital, and I'll talk about that too. So I work primarily in movement disorder, Parkinson's largely, and some of you know me?
Yeah.
How many of you know me? Well, that's quite a lot of you. And some of you might know Nini, who is our local heroine, yeah? Love Nini. And I just want to talk about the work I do, how I integrate research as much as I can into my very full clinical job, and some of my passions. This is going to be me talking about what I'm passionate about and what I try to bring to the people with Parkinson's that I look after and work with. So I'm going to talk about how the model of Parkinson's care looks in Teesside and how that looks a bit different over the extent of the geography that I manage. The PASU model, has anyone ever been to PASU or know what PASU is? No? Spoilers, it's Parkinson's Advanced Symptoms Unit, and it's awesome. Nithea's been, and it's awesome, isn't it? Hard to say no, but yes it is. Talk about a bit of evidence that we've used to keep PASU running, because it's hard to keep services running in today's NHS. I'm going to talk about clozapine. So clozapine is a central treatment that we use in Teesside. We're one of the only places in the UK that are able to deliver. And I'll tell you why that's important, and we'll talk about how we're trying to help other people in the UK deliver this, I would say, life-saving treatment to other people with Parkinson's. Right, so this is James Cook. Some of you might have been to James Cook before. The Cook, as people in Middlesbrough call it. This is called Cook's Earth, and apparently it costs a lot of money, but people like it, and people stub out their cigarettes at the bottom. And then next slide, please. So, Teesside and South Teess. Why are the patches that I cover very different? So, does anyone want to just shout out what you see? So this is Middlesbrough for me, and these are some of the famous sons and, well, maybe not daughters. I mean, the cat might be a girl, I don't know. Parmo. You can get a Parmo in Darlington. So probably will contribute to one of the statistics that I'll talk about soon, the Darlington Parmo. Riverside Stadium, I drive past it every day. It is the temple and the church of Middlesbrough. I think that's the Transport Bridge and Valley. He's not coming home to Middlesbrough for Christmas, but he's one of our famous sons. Teesport, it's quite nice, you can go there for meetings now. Heavy industry and the decline of heavy industry defines Teesside. Do you know who this fella is? Bob Mortimer. He's proud to come from Middlesbrough. And Paul Daniels, one of the best quotes ever from Mrs. Merton. So tell me, Miss McGee, what first attracted you to multi-millionaire Paul Daniels? And obviously James Cook at the top. Next slide, please. And this is part of Hambleton, Richmond and Northallerton, which is the other patch that I cover. It is a very different place. Does anyone recognise anything in here which kind of anchors Northallerton, Richmond and Hambleton?
Whitby Abbey.
Whitby Abbey?
Betty's.
Yeah, Richmond, Betty's. We've got a Betty's in Northallerton, you can get there from here. If you've had a really bad clinic, which you don't often do in Northallerton, you can get yourself a nice scone afterwards, if you take out a mortgage. The Georgian Theatre in Richmond, beautiful. You can see some very early period plays there. Do you know Lewis Carroll. So Lewis Carroll wasn't born in Croft nearby, but he did spend his childhood there. He was a mathematician. He was a funny onion. He wrote Alice in Wonderland and Through the Looking Glass. You know, the Queen Victoria loved those books and asked for more of his books. He didn't write any other fiction, so he sent her all of his maths textbooks that he wrote. He was not executed. Next slide, please. So, slightly more sobering, but just to kind of anchor it all down. When I do my clinics in Middlesbrough, my clinics in Northallerton, I'm very aware of the differences in demographic and the differences in wealth. And that's not to say that when I see people in Northallerton, there are poverty, there are, but I thought when I was writing this presentation, I'm just going to have a little look at some of the statistics and see whether it aligns with my, what I see. So the average age that a man can expect to live in the UK is 78.8 years. The North East on average is lower. I forget the actual statistics, something like 75 or 76, but it's lower overall in the North East. In Middlesbrough, if you're a man and you live in central Middlesbrough, you can expect to live 75.4 years. It is the 10th lowest in the UK. The lowest is, and has been for many years, central Glasgow. Hamilton, Richmond and Northallerton, the average age is 81 years, which is above the UK average and above the South East average. It is the 6th highest in the UK. They are 30 miles apart, and I do clinics in both of these places. Next slide, please. So, whether I do clinics in Northallerton or Middlesbrough, there is not very much of me, there's not very much of my colleagues. We are a huge area in Teesside. We are a very small department. We are passionate about what we do, but our numbers of patients are growing, and as much as we try, we are not growing. And if anything, we are probably a bit smaller than we were before COVID. And has anyone seen this slide before? Lynn, I know you have, but this is Sara Rogare. She's a Swedish engineer who now works closely with Parkinson's Sweden. I think Parkinson's UK, Sweden, Parkinson's. And she created this diagram to illustrate that even in really good services that try and engage hard, on average you'll have about an hour or so with your Parkinson's team in a year. That is the red dot. The blue is self-care, okay? So if we can't increase the number of red dots, and the NHS doesn't have as much resources as we would like, as hard as we fight for it, we should keep fighting. If we can't make more red dots, we need to make the red dots more meaningful. Next slide, please. So that's where PASU came from. So PASU is the Parkinson's Advanced Symptoms Unit, and that came from the fact that we know that we don't have as much time with our Parkinson's patients as we would like, so we need to make it meaningful and we need to make it count. So when you see someone with Parkinson's for the first time and you diagnose them, people used to call this the honeymoon period. I don't really like that very much, but generally you can instigate plans and things go relatively smoothly for the most part. As people's disease moves on, you add complexity, and that means that people's needs grow. When more than one service is needed, when you see someone in clinic and you might think, I think this person will benefit from a mental health assessment, from occupational therapy, from physiotherapy. I want them to see a Parkinson's disease specialist nurse. If you're lucky enough to have a specialist pharmacist, we've just appointed our consultant pharmacist. It was 3 days ago. Or a neurologist, if it's one of those other people. The combined referral time and to arrive to those specialist services, and remember this was back in 2016, so the waiting times have grown. It was 120 days to access all of those cumulatively. And the combined cost for them to be referred to and be assessed by all of those services back then was about £668. So we thought, what if we all came together, learned from each other, got good, and offered a single service and gave it a name? Would it be cheaper? Would it work better? We think it would. So we created PASU on a promise and a wish and 47 pence. No, we did manage to get some money, but it was conditional on the fact that it delivered. And it's really hard to deliver services for things like Parkinson's disease because you can save money, but often people want upfront cost cuts. And that's not how chronic disease works. But we managed to get some money. And back when we first started up PASU, if people needed PASU, if they needed more help, they could go to PASU within 10 days. It's no longer 10 days, but people can get in within about a month. They would see all of those services there and then. We have Jackie, our CPN, our mental health nurse. We have Deborah, who's a super specialist OT in Parkinson's disease. Claire, super specialist physiotherapist in Parkinson's disease. We have Viv, now our consultant pharmacist in Parkinson's disease. And you would either see me, a neurologist who's a specialist in palliative care, advanced planning and advanced symptoms. You would see Archie, who's a neurologist who's a specialist in cognition, hallucinations and dementia, or you would see Kirsty, who is a geriatrician who's a specialist in older people and how Parkinson's interacts with other diseases and other conditions like heart problems and such. Combined cost per patient was £450. And it's a triumph. PASU is something that we really value, and PASU is something that our patients really value as well. I do say it's the happiest time of the week is a Wednesday now we have PASU. PASU has almost had its funding withdrawn several times, despite its success and despite what we've been able to prove. The last time funding was almost withdrawn for PASU, Archie had to send a picture of himself receiving an award for PASU several days earlier, and then the funding was not withdrawn. But these services that are valuable, that work, we can never rest on our laurels because we can't assume that they will always be there. So we have to show that we value them, and we have to show that they work, and PASU works. And we know, well, one of the other reasons we know it works is when people come to PASU, they say, can I come here every time? That's not how, PASU can't be set up like that. It needs to be available for people when they need it, otherwise we just get booked up like a routine clinic. But that shows the value of PASU. So some of the ways that we proved that PASU has worked is we looked at hospital admissions for people with Parkinson's disease, which reduced by 7%. There have been other years subsequently where the reduction in hospital admissions was greater than that, but we have a significant and sustained reduction in hospital admissions for people with Parkinson's disease that we see. Hip fractures consistently been reduced by about 50% because we reduce falls. Nursing home admissions reduced by just over half. That's really significant. So I think when people have complex Parkinson's disease and symptoms can't be managed, there's care restraint. If people are obligated to go into residential care, that has a significant effect on people's quality of life and the quality of life of their families. And keeping people well enough to stay out of residential care is immense, in my opinion. And psychiatric admissions fell by 100%. So we have had one or two people have to go into psychiatric care since then, but I will point out that we manage their care. The team that know them manage their care. Rosebery Park is right next door, which helps. So this is PASU. I'm taking the picture, if you're asking. Also Viv, our consultant pharmacist, is not on there, but Santa's there, so that's fine. So it's evolved over time, and we have more services, we're developing, we're growing. We have the dementia clinic in the afternoon, so people starting on cognitive enhancers can be reviewed and assessed. Claire and Deborah are now training their replacements, their legacy. So we have more physio and OT resilience. And we have people coming all the time to train because they're interested in PASU. And in the future, we would like to enhance the services that we offer. Things like Pro-G-Redopa, programming our own DBS, things like that. That needs time, that needs resource. But we're fairly determined in Middlesbrough. We're quite gritty. And it is the best day of the week. So, talking about complexity of disease leads me to clozapine. Does anyone know what clozapine is? Has anyone heard of it? Nithya, no, you're not allowed to answer. It's an antipsychotic drug. So clozapine is the only drug in the UK, but I think probably also in Europe as well, that is licensed to treat Parkinson's disease psychosis, which is a rare but very serious and hard to treat complication of Parkinson's disease. It is one of the most significant factors in admission to nursing home, falls and distress in carers and patients. And that's because it's very difficult to treat. So when you think about psychosis in conditions like schizophrenia, we use antipsychotic drugs, and they are essentially dopamine blocking drugs. Immediately you see the problem there in the context of Parkinson's disease. The most traditional antipsychotic drugs are contraindicated completely in Parkinson's disease because of the devastating effect on the physical function of a patient. Even the newer, what we call atypical antipsychotic drugs, have a significant effect on Parkinson's disease. Even in people without Parkinson's disease, if they're used for a long time, people can have the appearance of Parkinson's disease and some of the symptoms. We call that drug-induced Parkinsonism. So quite a lot of patients I see have schizophrenia, and I'm asked the question, is do they have Parkinson's, or is it the effect of the drugs they've taken for a long time? So they are really not ideal in people with Parkinson's. And in much older, frailer patients with Parkinson's disease psychosis, which is quite often the group that are affected, antipsychotic drugs can be very physiologically damaging for these patients. So none of it ideal. When I was working with Rachel, there was a new drug that was just about to come out in the States called pimavanserin. Do you know the whole pimavanserin thing? I was like, oh, pimavanserin! I was just mad about pimavanserin, like you're obsessed. But the thing about pimavanserin was it was developed to safely treat psychosis in patients with Parkinson's disease. And I couldn't wait, because I'd seen what psychosis in Parkinson's patients does to people. And I wanted and I needed a tool to safely treat it. And then it was not licensed in the UK, and I was devastated. I was absolutely devastated. Over time, and Rachel and I went to Copenhagen for the Movement Disorder Congress last year. It turns out that in the States, pimavanserin has not been particularly successful. So it looks like Europe and NICE actually weren't wrong, and pimavanserin failure is very, very common. So not only is it an expensive drug, it's often not successful. And I was pulled up by a lady from a New York State University hospital. Can I tell you about this case? I'm not going to do a New York accent. She didn't know a New York accent. We had a case of pimavanserin failure, and we started this patient on a drug called clozapine, and we managed to successfully treat the psychosis. I was polite. I was like, oh, okay, yeah. She said, have you ever heard of clozapine? I was like, yeah. Yeah, we have a service in our hospital. We went, where's your hospital? I said, it's a wee town in the north of England. And she went, oh, good. And I went, okay then, bye. But it was a great moment for me. But it shows that this drug is not often used, and it can be immensely successful. So there are very few regions that are able to supply clozapine for a lot of logistical reasons. So clozapine, although it's the only drug that works in Parkinson's disease psychosis because it doesn't cause any worsening of the physical symptoms, it's a tricky drug to use because it can potentially cause problems with blood counts, and that can be very dangerous. When it was first used at very high doses in patients with schizophrenia, which I think we can all agree can be a fairly chaotic patient group because it's very hard to engage patients with schizophrenia who have no family support. It's hard to keep them regularly engaged with services. They would not go for regular blood tests, and it was often dangerous, and they might become unwell and develop what we call neutropenic sepsis, overwhelming infection. So there's a lot of caution around clozapine, and it's very carefully regulated. To get your next dose of clozapine, you must have blood tests at a registered clozapine clinic at a mental health institution, and then you're given your next dose. And clozapine is, to be on the clozapine service, you must have your bloods checked and be regulated by a psychiatrist. Now, psychiatrists generally who use clozapine, they use it in young, strong people, and they are extremely reluctant to use it in an older, frailer demographic. So if you try to get clozapine for your patient who was often older and had lots of other medical problems, you just couldn't get anywhere. And this happened all over the country. So in the end, when I was a registrar, Neil Archibald, who I now work with, fought and eventually achieved a clozapine service in South Tees by becoming an honorary psychiatrist. So he now, and I, and Kirsty, are registered as honorary psychiatrists. We are trained to give clozapine, and we give clozapine only to patients with PD psychosis. And we give it at extremely low doses. So we don't have anyone above 50 milligrams a day. People with treatment-resistant schizophrenia are often on 200 to 400 milligrams a day. So it's a whole other order of magnitude. And it changes lives. And I have a video to illustrate that. The patient was very keen for you to see. There are a couple of other places in the UK that have been able to source clozapine for their patients with PD psychosis. There's one in London, and that's a psychogeriatrician, so a psychiatrist who sees older people. There are a couple of interested psychiatrists in Scotland, and there are some geriatricians in Southampton. But otherwise, there are one or two places. If you have PD psychosis in the UK, you cannot access NICE recommended treatment for it. So clozapine the clozapine tips that we have, the numbers are small. So we've had 33 patients who we felt needed clozapine due to their PD psychosis. Most of them had had Parkinson's for about 11 years by the time they developed PD psychosis, and the psychosis improved in 27 out of the 33 patients. And in all of the patients, their tremor got better, their agitation got better, their sleep got better. They were just transformed. 7 patients stopped clozapine, 1 became very sleepy, several no longer needed it because they were no longer psychotic, and in 1 patient we withdrew it because they were reaching the last days of their life, which was not related to the clozapine. Initially, when you needed to start clozapine, when we first started giving clozapine, you had to admit to Rosebery Park, which was a psychiatric inpatient bed, at a cost of around £10,000 to the NHS. When we got better, we said, right, we don't think we need a psychiatric bed. Can we give this in the neurology ward as an inpatient? £7,000. And there were no complications with that. We are now able to safely initiate clozapine as an outpatient. And vast savings to the NHS, and it can be quickly delivered to people who need it. And we're very proud of that. So I'd like to just share a video. So the patient and his family are always very keen whenever we talk about clozapine for this video to be shown. I'll just let him speak for me.
So Michael and James, we were talking a bit about clozapine, which I think you've been on now for a couple of months, and we've been sort of tiptoeing gradually up with the dose. Take me through the last couple of weeks then, in terms of how you've been. Have you been better? Because you were having a horrible, horrible time with some really horrible hallucinations. Can you remember what they were like?
Well, it's like I watch 2 dogs. You know, I watch them, and literally, you know, you see these movies of like animals decaying, and
yes,
he goes in the fast forward, and
yes,
you know, it was like that. I was watching the dog, and it was just coming apart.
So the dog was coming apart, and
the legs came off.
Right.
Head.
Right.
The thing is, you got to know, the dog, all that was left was the head.
Right.
And it was just.
And these were your dogs?
Yeah, the tiny little. I don't know, spiders, maybe, or
yes, insects.
Yeah, and the dog would be laying, and the same just like going up the leg, eating them away, sort of thing. And
right, that's horrible.
I'd be going around, I'd be getting them up, standing them up, brushing these things off the legs and the body. And, you know, James would come and say, "What are you doing?" And he said, "Oh, yeah," I'd say, explain to him. I said, "No, there's nothing there, Dad."
What about you used to get a feeling like there were insects on you, I think, and in your bedroom?
Yeah,
you actually feel them biting you, couldn't you?
Yeah, I was feeling like the back of my throat. And,
all right.
oh, it was a horrible feeling.
And James, what did your dad used to do to the bedroom?
He'd trash it, like, he'd turn it upside down, but then he'd refuse to say it wasn't him,
right.
Somebody else did it.
Right.
But then he could be in a trash, like, room. Like, he'd say it was like magic that, how did this happen?
Right.
You think someone come in and do it, someone else do it, then
because it was weird.
He doesn't have that no more, even where he used to obviously try to escape from the house, but he'd wake up and still be in that lingo of half dream, half,
yes,
and he'd be lost, he wouldn't know where he is.
Right.
He doesn't do that no more.
And bedtime used to be, I think it'd be fair to say you dreaded trying to get to sleep.
Yeah.
Right, yes, well, yeah, which is an impact on both of you, didn't it? But yeah. So you didn't sleep for most of the night often, and you were doing a lot of hallucinations through the daytime as well.
Yeah, it was.
And so over the last couple of weeks, then those sound like those have been much better.
Yeah.
100%. Like during the day now, I'd say he's like pretty much spot on. Now and then in the night, he has a few daft moments, but it's not.
Yeah. Well, don't we all?
When you were talking about it there, and I'm thinking back what it was like.
Yeah.
How long ago was it?
Just a couple of months back.
I can't believe I didn't realise the difference in him.
Yes.
Until you say, like, I remember the girl ghosts coming in, the bugs on him, throwing water on the rooms.
Oh yeah.
It's like I still.
This is what clozapine can mean to people. So I remember when Michael was admitted to hospital before we could get his clozapine into him, and how horrible it was for him, the experience for his family, and that's after 2 weeks. So he was not fully titrated at that point. This was a while ago, and Michael has since passed away of other problems. But until he died, he was lucid. He had the occasional hallucination. But I feel that clozapine gave him his life back. And the time at the end, I feel, is just as valuable, if not more, than the time and the years going up to it. And I feel that passionately. And that's why I think that everyone should have access to clozapine if they have Parkinson's, if they need it. I just really wanted to show this video. So this is a little model of how we do things in Teesside. This is from a wee paper that I wrote over Christmas, because I agreed to do it over Christmas for my Christmas holiday. It is available if you want to read it. It does talk about management of all neurological disorders and how to manage symptoms in the palliative phase. Parkinson's is obviously a big part of that. But I did put together a wee diagram just to show how we manage Parkinson's in a holistic way in Teesside, and how we try to make sure that from diagnosis to death, from whatever cause, we are there for people in as much as we can be. And when I was a trainee, and Rachel knows this, I could not decide about whether I wanted to be a neurologist or a palliative care physician. And I could not understand why people with complex neurological disorders were too complex to be cared for in the community by their GPs when things were straightforward, and then when things became too complex and they struggled to get to clinic, they struggled to access their specialist, it was then fine for them to be left to their GP, to district nurses, and the specialists were no longer involved. I could not comprehend why that was the case. And even in the time it's taken for me to become a consultant, I think that prevailing belief has changed, and neurologists are invested in the idea that we are there for patients throughout their disease. Obviously, we wish we had more resources, we wish we had more presence in the community, but I am so glad that things have changed in that way. And I now say that I'm a neurologist and I'm a palliative care physician. I'm not accredited, but I approach all of my patients with a palliative approach because I want their lives to be better, no matter where the disease is. So in terms of other projects that we're doing in Middlesbrough for Parkinson's disease, we are part of a clozapine action group. So we're trying to write guidelines for NICE, and that's connected with PD UK are involved with this, trying to find ways around local challenges, geography, traditional service setups, so that others can set up clozapine services so that their patients can access it. So that's underway. And I'm also doing some work with our clozapine data to try and further that to support other people to make those applications. I'm doing a bit of work looking at advanced Parkinsonism at admissions review. So folks that come into hospital with Parkinson's, particularly if it's more advanced, why have they come into hospital? What are the causes? And then doing a little bit of Ludwiging, a little bit of Agatha Christie. Is there any way that we could have prevented this or changed this or improved the outcome? So work's ongoing with that. We've been involved with Chief PD, which is a drug trial. Obviously, I am a clinician foremost and predominantly. I work with patients, and I don't have a lot of time for abstract research, lab-based research and drug trials. But certain drug trials, I think, are very helpful to my patients on the ground there and then. And Chief PD with Emily Henderson was one of them. And that was looking at cognitive enhancers, specifically rivastigmine, to try and reduce the risk of falls. And the patients that were involved, I think, got real benefit from that. And it's being analysed, and spoiler alert, I don't think there's any way that cognitive enhancers will not help prevent falls. But I've not seen any. It's not a true spoiler, because I don't think but I do. And we also have recruited, a new consultant in the neurology department who has a cognitive interest. So I'll be working with him for more projects looking at cognitive impairment and trying to improve clinical outcomes. And a lot of those will involve patients with Parkinson's disease, dementia, mild cognitive impairment, and Lewy body disease. So this is us. This is the Parkinson's disease service. My picture. I didn't choose a picture. That's one of my cats. crazy cat lady. This is Sue, this is Charlie, this is Kelly, this is Anita, this is Claire, this is Rachel, Archie, Viv, Jackie, some woman with a cat. And this is ProAct, which is our new funded service to try and improve outreach for our patients who need specialist OT and physiotherapy. They went with ProAct. I was very keen on Pop-Tarts, and I was apparently it was inappropriate. So I am on call right now, and my colleague is holding the on-call phone, so I need to rip off these mics and then dash back in the car and drive back to James' call. So he's not on here, but thank you, Dr. Patil, for holding the on-call while I'm here. This is Alex. This is one of our movement disorder fellows who's worked with me on clozapine. He said, "What sort of picture do you want to do?" I honestly said, "Do you have any of you standing in front of a steam train?" I'd like to thank Neil Archibald, excellent hat wearer and an excellent colleague. Kirsty would not allow me to have a picture of her on here. I'd like to thank the Parkinson's disease team of South Teess and our patients. Some of them are here. You're all amazing. This is why we do it. Don't only fight for what you want, but fight for what you already have. I will keep saying that. Because never rest on your laurels. Even when services are proven to be fantastic, there's always the risk that can be taken away. So remember this. And this is just a view from Rosebery Topping, which I jumped off recently for Macmillan. I live it still. Does anybody know what that view inspired? The vista, and you can see the industry of Middlesbrough, and then North Yorkshire going ahead of you. Does anyone know what that inspired? This is a good one. The Lord of the Rings. Mordor and the Shire. I would not say that Chris Ree was driving home to Mordor. I'm very fond of Middlesbrough. I think it has a lot of strengths. I think the people there are wonderful. Thank you for having me. Have a great day.
Thank you so much, Lou. So, because you've got to go off your clinical duties, and just to keep to time, we'll not have any questions.
I can do a couple.
today.
I don't know time.
If anybody's got
I need to take the goblins off, so shots to warn into silence.
No, that was wonderful. Thank you so much, Lou. We don't want to take any more of your time, and we know you've got to. Oh, is the one?
Hello, just what do you look at? It's so important to keep the funding going for what you have.
Yes.
And then what we'd like.
Yes.
You would like. Do you get any funding or feedback from Parkinson's Youth Care or the government with our new health minister, who is really for Parkinson's at the minute? So,
I've not seen anybody from Wes. Parkinson's UK obviously are fundamental in pump priming various services. So our huge North Yorkshire patch, which I cover, until quite recently there was no dedicated Parkinson's nurse there. So they did pump prime the Parkinson's disease nurse role there. So Parkinson's disease UK are very integral in helping to, but even if it's not directly financial, they can help advertise and promote these services. It's very, as we were aware, very hard to get rid of a service if you've just gone to pick up an award in a ball gown. So and often it's embarrassment. You know, if people are hugely invested in a service, and lots of people are writing to, I'm just talking about agitation and rebellion here, but go with it. If a service is threatened and you value it, write to all the people involved. Don't write to the people who are trying, well do. I mean, you can write to me, you can write to Archie. But we want to keep these services, write to the people above us and say, this service is valuable. We need it. Look at all the things it's achieved, look at all the things it does for us. Because the thing is, silence is easy. But if there are lots of people actively valuing something with their voices and with their emails and with their letters, it's then very hard to dismiss that. We need to show that we're a community of people that value these services.
So somehow we have to muster everybody in the area to keep tabs on what's happening with threatening your funding, and we need to let...
It's not just this.
No, I know, it's not just you.
But yeah, absolutely. So just keep abreast of what you have available in your local service. And if those things are being threatened or reduced, then use your voice. Use your voice, because the thing is, I'm going to be honest here, there are certain things that are attractive and sexy in healthcare. Anything, Gesundheit, anything where you can do an operation and discharge, they love that. They love that because you pay for something and then it's done, discharge. Medical services where people have progressive or chronic conditions are expensive because there's not a pill or an operation to fix it right off. And that makes it less desirable politically. That's why there can be lots of funding for things like surgeries and operating theatres and things. It's considered cost effective. But it's nonsense because if you have people who have uncontrolled disease, falls, their problems aren't being managed. If you have sons, daughters, wives, husbands having to leave their jobs to look after their spouse or their relative, not having an income, social services then suffer from the extra burden of people whose medical condition is suboptimally managed. It is so much more expensive, but it's not immediately visible in one particular pot. That's the thing. We prove regularly that overall these interventions are much more cost effective. If it's not, an immediate price cut for the fund that you can see right in front of you, it's a much more difficult ask. So use your voice.
Shybone's getting out, as the saying.
Yes.
And I think we're going to have to leave it there in the interest of time. Sorry, thank you so much.
You did answer.
What I was going to ask was, who do I write to as one of your patients who's just been told that my next appointment is 15 months after my last one?
I mean, if you write to your MP, they'll write to me.
Yeah.
This is the thing, and we have fewer neurologists per head of population in the UK than we have in most European countries. There are vacancies. It's difficult, but I feel there should be, the Neurological Alliance is quite helpful. So obviously there's PD UK, but also the Neurological Alliance, which kind of oversees, because the thing is Parkinson's UK oversees Parkinson's, but obviously geriatricians and neurologists deal with sort of wider neurological issues. So the Neurological Alliance is very helpful. And you will see that there are a number of ways to contact and to express that you feel that your local services need more funding and support. So the Neurological Alliance is also a very good one.
Thank you very much, Lou. And a round of applause one more time for